Hello, and thanks for joining today's webinar on oncology partnerships. I'm Elizabeth Liebow, principal at ECG. ECG Management Consultants is a national consulting firm focused entirely in healthcare with over 650 engagements in oncology, more than 300 oncology clients, and clients all across the US and internationally, both NCI designated centers and community-based organizations. I'm here today with my colleagues, Jake Campbell and Lee Mandell, and we're part of a group of a dozen consultants or so that focus exclusively on oncology, including lots of partnerships. And the reason that we wanted to do this webinar today is because so many of our clients are asking about partnerships. It's an area that I have a lot of experience in. I spent 20 years running oncology planning and strategy functions at Dana-Farber Cancer Institute, and before that at other Boston hospitals, and have completed dozens of partnerships, and I'm familiar with the risks and what it takes to do them well. And what's emerged over the years are some trends and some tactics, which we'll share with you, as well as where the landmines are hiding, which we'll also share with you. And we hope it's useful to you, and we invite you to get in touch with us if you have any questions. When I was barely out of college, I lost my mother to cancer. And in the years and decades since, so much about cancer is better. There are better treatments, the side effects are more manageable, the survival rates have improved, but not everything is better. And one thing in particular that's actually gotten worse is that the need for cancer services is outpacing the capacity of our system to treat all of the patients who need to be treated. And there are primarily three reasons why that's happening. There's better and earlier detection, which means there are more people getting treatment, and there are many more treatments available now than there were over the last few decades. There are many more oncologists at retirement age or above than earlier in their careers, as you can see from the numbers on the slide. And that's leading to recruitment challenges across the country. But really the big one is what you see in the chart here. The main reason is that cancer is largely a disease of aging, and the population is aging, and it's aging rapidly, with 12,000 Americans turning 65 each day. And you can just see this wave of people aging into the age when cancer is at highest risk. So this crunch isn't going away anytime soon, and is likely to get worse over the next number of years. I care a lot about this issue because if a diagnosis takes weeks to confirm and you can't get in to talk to a physician or start treatment, it's agonizing for the patient and the family. And I'm sure we all know someone in that who's been in that situation. But I also care about it because cancer growth is vital to hospital viability. It's generally the top one or two margin producing service line, which means the margin is supporting not only services to cancer patients, but also supporting other critical areas like obstetrics and pediatrics and primary care, which typically run at a loss and which we're seeing more and more closures of those services. So if oncology is such an important service line financially, why does it make sense to partner rather than to do it all yourself? That might seem counterintuitive, but most hospitals can't grow their programs to a size and scope fast enough alone, either because of recruitment challenges or access to clinical trials or support, not having enough support services or labor issues. So partnering is most often necessary to grow and to maintain profitability. And even what we're finding is even the largest and most advanced programs in the country can't be all things to all people in all geographies, and all of them have partnerships as well. But if a hospital were able to provide the full range of cancer services with enough capacity in all geographies, while also keeping pace with the rapidly changing standards of care and clinical trials in each oncology subspecialty area, then yes, it would make sense to go it alone. But in our experience, it's generally not possible to maintain sufficient oncology access, market share, and margin in isolation. And partnerships, when they're set up thoughtfully, can help cancer programs thrive. So partnerships are necessary and important, but many fail to launch or to launch as robustly as they could, or they fall apart after a short time. They're tricky for a number of reasons. They require giving up some control, which is inherently risky. How do we know the quality at this organization? Will it hurt our reputation? What will the financial impact be? Those are some of the things that people worry about when they consider partnerships. Doing a partnership successfully also requires bringing along many internal constituents that, especially in an academic medical center with its multiple missions, may not be fully aligned with each other. And between an academic medical center and a community program, there will inevitably be town-gown issues. I would say that I think it's fair to say 100% of the time when I've supported partnerships between or executed partnerships between academic medical centers and community programs, those issues have come up and needed to be worked through. Partnership discussions are often reactive to an urgent need or an opportunity and proceed rather than follow the development of a network strategy. And this is where a lot of partnership conversations get derailed. If there's not a clear vision and consensus on what you're trying to accomplish and how it fits with your overall strategy, it's very hard to navigate business terms. And at each sort of milestone along the partnership path, if there isn't a clear vision to hold on to, things can go awry. And then finally, partnerships often go awry because they need sustained effort and patience, which is hard for any organization today, and many don't dedicate the resources sufficiently. So partnerships are worthwhile. They're tricky. They have road bumps. What should you think about before launching into detailed planning? And what can you do to make them successful? To look at the key decision points and best practices, along with some specific case examples, we'll now turn to Jake Campbell, who supported many oncology partnership discussions and transactions. And Jake will walk through getting prepared, internal clarity and consensus on your rationale, assessing organizational readiness, and identifying the right partners. And then we'll hear from Lee Mandell, who has also supported many partnerships and transactions, on developing the business terms and picking alignment structures, the core elements of affiliation modeling, and then the transaction milestones. And then I'll come back with some key takeaways in the conclusion. So thanks again for joining us. And Jake, I'll turn it over to you now.
Thanks, Elizabeth, and hello, everyone. So organizations can generally evaluate partnership options from two angles, either proactively or opportunistically. The proactive approach involves organizations taking internal steps to evaluate what it is that they need. It also typically means conducting internal analytics on program strengths and weaknesses, and scenario planning where build, buy, or partner assessments can be conducted. An opportunistic approach, on the other hand, is more passive. Organizations with this approach might wait for others to come to them, and response and action times are generally not as urgent. Neither approach is wrong, and the discussion today will include applicable information for both approaches. A critical step in partnership planning and the execution process is really the legwork that organizations have to do before they decide to partner. So broadly, this work covers three areas, including an analytic self-assessment, a resource evaluation, and defining your value as a program. So what exactly do we mean by analytic self-assessment? Well, before pursuing a partnership, organizations have to examine their program's strategic plan, and they have to have real explanations for what that plan means in terms of growth. What does it mean for programmatic capabilities and service offerings? What about technological advancements or service area reach, community presence, infrastructure, personnel, capital investment, etc.? So you have to be able to articulate what your programmatic goals mean for all of these things. And often articulating that first requires conducting market assessments or competitor analyses. Maybe it includes internal department interviews or program performance evaluations. Likely, you'll want to look at payer scenario modeling and determining your organization's risk tolerance for an investment. But more than likely, it's going to be a combination of all of those things. Beyond that, a cultural evaluation should also be completed just to get a sense of what impact a prospective partnership would have on employed providers or staff, as well as any existing contracted providers or services. But asking questions such as, Does our organization have a collaborative culture that will support change, or will there be resistance to potentially modified operations or shared governance? How much of a risk does organizational and program culture pose to a successful collaboration? These are all good questions to start asking yourself, and the internal department interviews that I mentioned are a good opportunity to just start getting a feel for this. Once those elements are understood and strategic plan implications are thoroughly defined, you have to ask yourself, do we have the capacity and the capabilities to execute on a timeline that aligns with our strategic objectives? So this means doing a further internal assessment to determine if the organization has the resources, whether personnel or financial, and the expertise to execute the strategy and to do so in an efficient way. Once equipped with this intel, organizations are in a much better position to determine if they want to partner to realize any of those strategic goals. Then for organizations which elect to pursue partnership discussions, it's always helpful to know the strategic position from which your organization is coming to the table. Do you have all the resources you need to execute a strategy independently, or are there key missing ingredients driving the rationale to partner? In either case, organizations which choose to pursue partnership discussions have to prepare to come to the table with a clear ask and a defined value statement or value proposition for their prospective collaborator. So you should use the analytic self-assessment and the resource evaluation to help clearly define what that value proposition looks like. So another element that helps specify that value proposition, and one that's important for any partnership consideration, is having a strong understanding of your program's rationale for partnering. If you're considering a partnership, you have to have a clear motivator, as this then starts to inform the possible range of affiliation models as well as the list of prospective partners. I know it seems obvious, but knowing specifically which element of a strategic plan for which you are seeking to partner and then what specifically that partner needs to bring to the table helps the planning efforts go smoother, and it positions you for a more efficient conversation later in the process. This is also what enables a more specific assessment of that cultural impact as it becomes clearer who and what will potentially be affected. So common motivators for partnerships include geographic expansion, improving community access to high quality or close to home care, increasing accruals to clinical trials, maybe it's projecting the brand, and depending on the motivator or motivators, organizations may be prompted to partner to expand provider capacity or to enable the provision or management of a new service. Maybe the partnership would reduce barriers related to real estate, or maybe it just to help finance an expansion. In cases where organizations have the resources and they have the expertise to execute strategic priorities independently, motivators could be more along the lines of reducing risk, such as through cost sharing, accelerating timelines, or just planting the seed for a more large-scale partnership in the future with a specific organization. As a recent example, just to support the points thus far, our firm worked with an academic program who wanted to expand its oncology presence into a neighboring city. The organization could have done this on their own, but they came to the realization that the capital and timeline associated with constructing a new center, recruiting the medical and professional expertise, and building the brand in a new community represented a significant level of risk and a slower return on their investment. And so the organization elected to pursue partnership discussions. However, before making contact with any prospective partners, that organization completed a comprehensive self-assessment. So they evaluated their market share, they conducted qualitative program evaluations, they looked at their year-over-year disease site growth performance, assessed their financial strength, and developed long-term program objectives. The team also recognized that they had a leadership group with transaction experience, and they also had internal as well as outside counsel to help facilitate conversations. They collaborated internally, and they developed a concise summary of their goals and objectives, which enabled a candid conversation with prospective collaborators without revealing any sensitive information. And it gave the organization a clear way to filter prospective partners just based on the organizations with which those goals and objectives really resonated. But I think, most importantly, those internal analyses, that pre-work, it gave the program concrete data, and it gave them the confidence once it was time to enter into more detailed partnership conversations, just in terms of what their value was and what they brought to the table. Once an organization has defined its internal strengths and weaknesses and its rationale for partnering, it has to review its ability to carry out the partnership planning process. So, does the oncology program, does the broader organization have the personnel and the expertise needed to lead the partnership planning journey? This might be might include a dedicated strategy executive, could be legal and regulatory experts, business development leadership, dedicated analytic resources, etc. And you should ask yourself, are there clear channels for rapid decision making? Have we properly engaged internal departments to collect those perspectives, and are we fully aligned? Do organizational and program leaders also possess critical competencies for partnership discussions, right? Maybe this is strategic thinking and vision alignment skills. Maybe it's negotiating experience or regulatory expertise. Maybe it's a history of successful change management, etc. Ensuring the organizational structure and the staffing to plan, implement, and manage partnerships is in place is equally as critical as the analytic pre-work and the rationale development when it comes to supporting successful partnerships. But with defined rationale, internal program evaluations completed, and proper personnel in place, organizations are in a much better position and are much better prepared to identify potential partners. And once more, partnership rationale has a direct impact on that prospective partner list as well as the affiliation models. So, for example, if the rationale is to expand existing capacity for a service such as medical oncology, an independent provider practice is a logical group to start with. On the other hand, if rationale or if program need is to introduce a new service, maybe your program needs radiation oncology just to better enable continuity of care for patients, then developing a partnership with a larger hospital program, maybe it's through a management services agreement, is a reasonable solution. Another driver which can help narrow that range of prospective collaborators is just fully understanding the scope of services expected to operate under that collaboration's purview. The identified strategic goals and the preliminary market analyses should then be used to complete an initial sizing of the opportunity within the market. Based on that preliminary sizing, your organization should refine the list of prospective partners to start with, just based on those organizations' expected capacity to support the overarching goals. Lastly, understand what your own non-negotiables are and identify the areas in which you have more flexibility. Ultimately, laying the groundwork for a successful partnership can be summarized by the following. Clearly define your strategic priorities and the specific implications those priorities have on your cancer program. From there, you can develop a strong understanding of your current program position by conducting the necessary internal analyses. At that point, you can summarize the gap between current and future state, and you can ask yourself, what does my program need to achieve its strategic goals? At that point, you determine if you want or if you need to partner with another organization to achieve one or more of those program goals. Identify the primary motivator for partnering and use this to develop your preliminary list of prospective partners. Further define the scope of services within the potential collaboration and apply this against the broader program's strategic priorities to complete an initial sizing exercise for the opportunity, using this information to just further distill that list of potential partners. At this point, you're in a good position to initiate contact with prospective partners, and you should be prepared with a concise summary of your organization's objectives and ask of the prospective partner. Enter into those conversations with confidence, using the strong understanding of your program and what your program can offer. Use those conversations to further filter the list and to select a preferred partner. So from here, I'm going to transition things over to Lee to talk more about the practical components of putting a partnership together and how to bring one to life.
Thanks, Jake. In this section, we'll focus on the practical next steps and key considerations that should drive the affiliation planning and execution process, with emphasis on designing, developing an affiliation structure or model. Once the two parties have agreed to begin modeling out their envisioned oncology affiliation, the emphasis typically shifts to the development of a non-binding term sheet. The goal with this critical step would be to work out as much of the detailed structural, operational, and economic ins and outs of the future state as possible, to establish a foundation for the drafting and execution of legal definitive agreements down the line. Depending on the parties involved and the mutual goals and ambitions for the affiliation, elements of the term sheet will necessarily change from case to case. However, the items listed here are fundamental examples of what we tend to see most often in planning processes like this. The fundamental building block of an alignment for clinical cancer care services will be the legal structure of the arrangement. There are a large spectrum of options available, each of which has its benefits and potential limitations, and the parties should make sure to consider each of the viable options in terms of their ability to generate the desired economic and programmatic outcomes. The high-level structural options laid out on this slide are meant to represent some of the examples we most typically see out in the market, ordered in terms of level of integration between the two parties. It's important to note that there are a number of other feasible options for potential partners to engage in. Whether we're discussing a hospital-to-hospital affiliation or a hospital-to-physician group affiliation, a spectrum of options are available, with full employment of physicians or acquisition of a hospital or cancer program representing the highest level of integration, and essentially a combination of contractual arrangements for provision of specific services representing a lower level of integration. These various affiliation structures will have an impact on the day-to-day operations of the future state cancer services, and they will also be critical in establishing mechanisms for the flow of funds between entities. We commonly see our clients utilize PSA, MSA, and co-management agreements as a means to ensure that each party is appropriately compensated for the clinical and non-clinical services they provide to the affiliation. It's also important to consider the regulatory implications of these legal structures. The ability of the parties to engage in certain affiliation structures may be limited due to governmental regulations, so investigating and validating the potential options with qualified legal counsel early in the planning process is key. One of the most common examples we faced with our clients regarding regulatory restrictions relates to affiliations that include medical oncology and infusion services, and specifically the implications around qualifying for the 340B drug pricing program. The program requires a qualifying site to be registered as a hospital outpatient department of the billing entity, and there are specific limitations for clinical joint ventures when the site is designated as an off-campus HOPD versus an on-campus HOPD. Examples such as that are why it's critical to get any initial concepts regarding affiliation structure and ownership in front of qualified legal counsel of both parties. As we work with our clients through the development of affiliation structures and key business terms, the core elements that we'll go through on this slide represent a few of the critical areas of emphasis during joint planning discussions. Regarding governance and ownership, we reviewed some of the high-level examples of potential legal structures on the prior slide, but it's also extremely important to establish the oversight body which will have responsibilities over the future state affiliated program or services. We typically recommend to our clients that they establish a jointly staffed oversight board, and it's useful to flesh out details around membership, meeting cadence, and responsibilities of this body early on for inclusion in the term sheet and definitive agreements. From a leadership, management, and operations perspective, it's critical to establish the clinical and non-clinical leaders who will maintain authority over day-to-day operations. Successful affiliations also typically include specific mechanisms for empowering the physician leaders to help drive program development, ensuring that they're appropriately incentivized to push the program forward. To that end, establishing a model for geographic expansion and funding of new cancer services, such as close-to-home outpatient infusion services, can also be an explicit inclusion into a term sheet, depending on the aspirations of the parties and the nature of the partnership. To the extent regional expansion is an element of the partnership, plans for physician recruitment should be established to ensure the future state program growth is supported by the appropriate specialist and generalist personnel. For obvious reasons, distribution of ongoing program margins and allocating responsibility for large-scale capital investments tend to be a focal point of all affiliation or partnership discussions. Capital investments such as building development, facility space renovation, or the purchase of capital equipment typically represent the largest one-time expenses associated with program development. So making sure all parties are on board with which entity is expected to cover which portion of these costs is a critical component to the planning process. Similarly, funds flow mechanisms for distribution of operating margin can be complex and involve different levels of risk tolerance. Ensuring that the appropriate contractual arrangements are in place is key, especially when one party is designated as the billing entity for all affiliated services. Other considerations that tend to impact oncology affiliations in particular are related to clinical research, so establishing protocols for the accrual of patients to trials and the management of the IRBs, and philanthropy, namely the coordination of fundraising efforts and assignment of any donated funds to support the future state program. While the items listed here are a subset of the broad spectrum of considerations that could or should go into an effective affiliation process, there are also some high-level best practices that we would suggest to help guide joint planning between the parties. First, make sure to include legal counsel from both parties early on in the process, particularly ones that have specific expertise in cancer and in developing partnerships. Utilizing the lawyers to identify potential regulatory hurdles and to validate any high-level concepts around structure can be an invaluable step in moving the planning process forward. I've personally worked with clients where a significant amount of planning time and effort was ultimately invalidated once the model agreed upon by the executives and the project teams were put in front of one of the parties' legal counsel, and the structure was deemed inviable. Early inclusion of legal into planning discussions can help to avoid that type of error and remove impediments to planning momentum. Similarly, engaging leadership and key stakeholders across the entities early and often is best practice, making sure that executives, physician leaders, appropriate board members, and others are kept aware of the planning process as it materializes. People tend to support what they help to create, so giving stakeholders viewpoints into the process and the ability to contribute feedback and guidance is a great way to build internal support for the endeavor. We've talked through some of the key considerations regarding the development of a term sheet and the designing of the partnership structure, but we'd also like to spend some time walking through some of the other critical steps in executing the partnership transaction and in establishing a groundwork for successful integration of the programs and implementation of the envisioned structure. As in any transaction, a comprehensive and efficient due diligence process is extremely important. Due diligence allows all parties to gain a comprehensive understanding of the current state and historical economic performance of all relevant services and programs. The parties can then use that detail to effectively project forward and forecast the anticipated performance of the joint or affiliated program in the future. It is critical to ensure that legal counsel has had a chance to appropriately investigate and understand the underlying details of the programs, so that nothing pops up down the line to potentially invalidate any of the detailed planning work done between the parties at a higher, more conceptual level. Another step we'd like to touch on here is the completion of a fair market value or FMV assessment as part of this process. Best practice is to bring in a third party or multiple third party valuation firms to develop an FMV assessment for any assets, personnel, or programmatic elements being purchased as part of the potential affiliation. An important note, this valuation will not include any buyer-specific impact or details, such as one party's participation in the 340B drug pricing program. The fair market value will be calculated based on the current state of the business or assets without any buyer-specific implications. Once the definitive legal agreements have been executed and the transaction has been completed, the integration and implementation process will begin. Depending on the complexity of the affiliation and the current state of the related program or services, this implementation process can be extremely complex and lengthy and require contributions from personnel across the organizations. It is critical to make sure that a clear step-by-step implementation plan is developed and that appropriate personnel resources are tapped in to help project manage and drive the process forward. And with that, I'll hand the presentation back over to Elizabeth to review some key takeaways and to close us out.
Thank you, Lee, and thanks, Jake, for these insights. You've heard a lot today. Oncology partnerships are key for most hospitals. Ability to keep pace with access, the latest treatments and clinical trials and their overall financial goals. And they're hard work and they're tricky. So these are some recommendations that we hope you'll take away from this webinar. The first is don't launch into a partnership without getting clarity and consensus about what you're trying to achieve. And don't wait to develop a network strategy. You want to go into partnership discussions being clear about what you want to get out of them, what's off the table, and how you'll ultimately determine if they're successful. Be selective in who you partner with. And once you decide, invest in the relationship and develop trust. Thorny issues will arise, and the more you have in the trust bank, the easier it'll be to navigate them. Don't focus only on the short term or try to win every point. And this is one I can't emphasize enough. I've seen partnership discussions go off the rails for this reason. The focus should be on doing better than you could on your own, as opposed to doing better than the other side at every turn. Try to create structures with aligned financial incentives so that each side does well when the partnership does well, and consider both upside and downside shared risk so that you either succeed together or fail together and each side has an investment in the success of the other. Don't underestimate the effort needed. Be sure to adequately resource the partnership planning with both physician champions and business leadership in order to bring structured, sustained focus through getting the document signed and beyond that, to put in the time into building trust and confidence in the partnership, and to make sure that you're bringing along all of the internal constituents. And then most importantly, as you go through these hard discussions, both internally and with potential partners, keep your North Star front and center. Partner because it allows you to provide more care, more comprehensive care, and better care to the increasing number of cancer patients who need it. And that will help get through all of the partnership discussions. We hope that you found this webinar useful. As you can tell, we really care about partnerships a lot, and we're always happy to talk further. Here's how to contact us if you have questions, or if you'd like a link to a recent podcast episode about a successful partnership that's now in its 10th year. And I want to thank you for joining today. Thank you to my colleagues, Jake and Lee, and to the Association of Cancer Executives for hosting this webinar.